Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy, era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype, T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TAS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype, T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TARS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TARS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without diabetes with dapagliflozin. Every sales pack of Dapavel shares your precious advice with the patient. Uncomplicate your diabetic patient's life with uncompromising quality and efficacy. It's time to offer them hope beyond possibilities, health beyond limitations, happiness beyond expectations. In T2DM with multiple risk factors, prescribe Dapavel. Wellness beyond diabetes control. Diabetes, one of the most dreaded disease in the world today, consuming hundreds of lives as we speak. But diabetes is just the tip of the iceberg. It's the underlying threats of diabetes that compromise and complicate the patient's wellness. The need of the hour is a therapy that offers wellness beyond diabetes control. In TARS, leaders in cardiodiabetotherapy unveils a new era of wellness for diabetes patients, introducing an innovative and holistic approach beyond glycemic control and emphasize heart and kidney protection. Dapavel, wellness beyond diabetes control. Indian phenotype. T2DM patients in particular have multiple risk factors and are at high risk of cardiorenal complications. Transform their harsh reality into healthy possibility with Dapavel. Dapavel offers powerful glycemic control. Large studies have shown cardioprotection and renal protection with or without.
Good evening and namaste everyone. On behalf of Intas Pharmaceutical Limited, I Dr. Mithilesh Nayak welcome you all to this first edition of webinar series on Spotlight on SGLT inhibitor. So today we are going to understand about the SGLT inhibitor, whether we can use it as a first-line therapy or not. Can we use it beyond diabetes or not? So to moderate today's session, we are having with us Professor Ganpati sir. He is a reputed and experienced endocrinologist practicing in Bangalore. He is currently professor and head department of endocrinology at St. John's Hospital and Medical College, Bangalore. He was principal investigator in more than 50 clinical trials and various studies, and has published several papers in various international and national journals. He is currently president-elect Endocrine Society of India. So with this, I welcome Dr. Ganpati on digital podium and request sir to take us further. Over to you, sir.
Thank you, Dr. Mithilesh, and thank you, Intas, for giving me this opportunity on this spotlight on SGLT2 inhibitors. So we have two eminent speakers for that. The first one is Dr. Bipin Kumar Sethi. He requires no introduction at all. He is a former professor and head of Gandhi Medical College, and presently now he is working as a consultant endocrinologist with CARE Hospitals in Hyderabad. Completed his MBBS from Osmania Medical College in Hyderabad, MD in Medicine and DM in Endocrinology from TGI Chandigarh. He's been the recipient of Economic Times Inspiring Doctors of India Award 2018 in New Delhi. Over the years, he has authored as well as contributed to innumerable papers connected to his field of expertise, which has been published in peer-reviewed journal. He's a very good orator. You will have to listen to him very carefully because every word of that has some wittiness and also a little bit of sarcasm also is there. So you must understand. For that, you have to listen very, very carefully to his lectures. So he'll be speaking on SGLT2, can it be the first-line therapy for diabetes? Just before that, I will just tell. Say around 2-3 years back, we had a meeting. I'm not sure whether Bipin was a part. That was in Hyderabad. So then there were cardiologists, nephrologists, endocrinologists. Cardio, and they asked a question, can we use it even before metformin? The cardio and the nephro told yes. But the endocrinologists were still reluctant. No, we told no, we can't replace metformin. Metformin is a thing. Probably time has come, probably we could even change our methods. The only advantage right now being metformin is very cheap. Time-tested molecule. We don't have great studies with that, but then it's safe. We know it reduces cancers, all those things and all. But then this SGLT2 is the molecule of the decade, I would say. We always used to think that a drug which is catabolic will always do harm, but not so here. So with these few words, I will request Dr. Bipin Sethi to start.
Thank you for your kind words. I'll have to live up to this reputation now, which is very hard. Let's see how this goes. I hope the slides are visible. Are they visible? Okay, thank you.
Yes.
Produced. So it was very surprising that a drug that would increase the urinary glucose excretion should be such a wonderful drug that we are discussing it like this as the first line of treatment. But more of that later. Diabetes, all you know, and I think this is not something which this audience does not know, it's not something to do only with hyperglycemia. It's all right when you have DK or hyperosmolar, state, then that is glucose is important thing. But for long-term problems, it is associated with microvascular disease as also macrovascular disease. It's a sole contributor to microvascular disease, but a minor contributor for the macrovascular disease. We know that diabetic patients are worried and concerned about two problems, the CKD and the cardiovascular disease, including heart failure. Both of these can occur with increased numbers in patients with diabetes, and they also tend to crosstalk with each other, as in, if you have got cardiovascular disease, then you can get CKD. If you got CKD, you've got higher incidence of cardiovascular disease. The highest mortality is in patients who are diabetics, who have got cardiovascular disease, who have got CKD. It is much more than those who have got cardiovascular disease and diabetes. When I was in PGI Chandigarh, where Ganpati also studied, our professor used to smile at people who used to ask, will I die of cardiovascular disease or kidney disease? So a kidney disease patient would ask the doctor that, sir, will I go to dialysis? And he would smile. He says, not necessarily. And we used to wonder why, because he used to say that this person might have myocardial infarction, might go away without requiring dialysis. This was the relationship which was known, and now this intertwining is even better understood. What with interventions that are designed for these two with protection to both these organs. We know that the risk factors for diabetes are many, but genetic predisposition and aging are very important factors, compounded by obesity. These individuals are also tending to be hypertensive. They have dyslipidemia, and if they have got smoking, then they have got all the things that are required for them to have the problems in the future. The major trials that were done prior to the advent of SGLT2 inhibitors and GLP-1 analogs did not show a major difference in the major cardiovascular outcomes. UKPDS showed that if you treat the patient intensively, after 10 years, you could get some difference in the cardiovascular outcomes. But if you look at the standard of care and intensive care, there were very minor differences. And we used to think that we are treating only glycemia, and we have to have a multifactorial approach, which was dose Pacino, stop smoking, control cholesterol, control blood pressure, and then you might have some influence. And we were thinking, and we were also being cajoled by cardiology colleagues that you are only controlling glucose, you're not interested in anything else. At the most, you may control nephropathy, and nephropathy may then prevent myocardial infarction by its cardiorenal connection, but direct intervention for macrovascular disease was not known. Then came the study, which was published almost 5 years ago, and it was it got an astounding reception in the EASD, which showed that SGLT2 inhibitors could decrease MACE. So the first example of that was empagliflozin, which we shall see subsequently. But SGLT2 inhibitors do not just cause increased glucose excretion. They rectify what is essentially abnormal in type 2 diabetic, that is upregulation of SGLT2 receptors. The body doesn't want to get glucose, which it has acquired and metabolized so with so much difficulty. It upregulates glucose receptors whenever the hyperglycemia is there. And therefore, SGLT2 inhibitors do address a pathophysiologic mechanism, which is upregulation of SGLT2 inhibitors in the kidney. And they have got secondary actions in terms of decreasing weight, improving insulin sensitivity, and also decreasing the insulin requirements, and can be protective to the heart as also the kidneys. These are drugs with a difference. And the first thing that came was the decrease in the major cardiovascular events. And if a person has got cardiovascular event to begin with, they have ASCVD, then there is a reduction in the cardiovascular outcomes. And it is not so if they do not have underlying cardiovascular disease. This was the difference that was seen with the EMPA-REG and CANVAS, which were done with empagliflozin and CANA, versus dapagliflozin, which was done in individuals who were having major risk factors as well. So many people had questioned the use and utility of CV outcome trials, and that's a waste of money, etc., etc. But what came out of this, like you say, Samudra Mathanam, came out of this came this portion of which has protected the heart. And there are various ways in which people have said that there is a person called Bruce Neal who says that these are drugs which protect the heart and the kidneys and also happen to control the glucose. There are various cardiovascular outcome trials, primarily with EMPA, CANA, and DAPA, which have shown that there is reduction in the MACE if you have got prior cardiovascular event. This was not the case with DAPA, and the reason we will discuss shortly. But more importantly, will be discussed by my subsequent colleague. They have influence on heart failure, and they have influence on CKD progression. For CKD and heart failure, these are the areas which were crying for help, crying for pharmacotherapy, and they were not good pharmacotherapies in CKD for years together. And heart failure till valsartan came, there was nothing much. The EMPEREC study, which was the first study, showed reduction in the cardiovascular death. The DECLARE-TIMI showed reduction in hospital heart failure, which was a co-primary endpoint, or CV death, but the MACE was not reduced. The reason for that was in DECLARE-TIMI, about 60% of people were having dyslipidemia, hypertension, smoking as risk factors, and they were individuals above 55 men or 60 women. But established atherosclerotic cardiovascular disease was not seen in 40% of people. Unlike patients in CANVAS, where 34% were not having established disease and 1% or less than 1% in EMPEREC. When people in this study were looked at, if they had a previous myocardial infarction, lo and behold, the same thing obtained. In individuals who did not have a prior cardiovascular event in the curve seen below, versus in the individuals who had a myocardial infarction or ischemic stroke previously, who had a myocardial infarction in the previous 2 years, there was a 16% reduction. So these drugs are good for reducing MACE if you have a pre-existing atherosclerotic cardiovascular disease. There are benefits of heart failure also, and this was also established with dapagliflozin in a study which was well conducted in diabetics as well as non-diabetics, and one was trying to look at the composite of CV death, heart failure, or urgent heart failure admission. And the main results were there that you had a reduction in the events that you were looking for in individuals who took DAPA. So if you give DAPA, you would have this benefit, and this was irrespective of diabetics status. So if you are diabetic or non-diabetic, and this led to the approval of this use, the use of this drug in individuals who are even not having diabetes. The detailed data also showed that there was a reduction in the events that you were looking for, hospitalization of heart failure and cardiovascular death. If the patients in the DECLARE-TIMI also had reduced ejection fraction, because this is the only study which had ejection fraction data, if you were giving dapagliflozin to these people, here also you had reduction in CV death, reduction in this all-cause mortality, not just hospitalization for heart failure and not just in the renal events, which was seen in the whole cohort. The renal outcomes also, in the studies that were done previously, this was the EMPEREC study, and if you do more of the cardiovascular outcome trials, you find that you have a distinct advantage in terms of whether you have requiring dialysis, ESKD, or substantial loss of kidney function, acute kidney disease, whatever parameter you see, the point estimates are favoring SGLT2, no heterogeneity, nothing else. Everything is on the side that you expect it to be. DAPA-CKD study similarly was done in patients who were having GFR of 25 to 20, up to GFR 25-29. And this included people with diabetes and non-diabetes, again trying to look at the composite endpoints and trying to see what was the difference. And there was a clear difference in individuals who were on dapagliflozin. This study was terminated prematurely, much like REDENCE, which was also terminated prematurely for benefits that DAPA people had, and in the other study, canagliflozin had. so that other people who are in the placebo arm are not denied this particular benefit. This was again seen in non-diabetics, and now non-diabetic CKD people, if they are proteinuric, have the option of taking another drug, not just ACE inhibitors, ARBs, and diuretics. In the CREDENCE trial, also you had a similar finding. The GFR there was up to 30. Now, after this cardiovascular outcome trial, actually real-world evidence to my mind does not matter, but real-world evidence was projected by dapagliflozin because they did not have an outcome study, but this also showed a similar benefit in terms of lowered cardiovascular risk. The advantage and beauty of this real-world evidence is they are representing patients whom you and I see in the outpatient every day, and they are not as tight-jacketed as people in the CVOT trials. Now, what are the mechanisms of benefits? So you may ask me that why should we ask about mechanisms of benefits if the benefit is there? See, for science it is important, but for art of medicine, yes. If somebody is getting benefit, it is good. The clear answer to this is not known. There are many projected benefits. Certainly, it is not lowering glucose, lowering fat distribution, lowering the weight alone, but it is possibly something to do with improving the vessel elasticity, improving the sympathetic tone. Some people say better ketone delivery to tissues, because if a child is sick and cannot eat the rice, you make a gruel and give it, and that's what SGLT2 inhibitors do. They produce controlled ketosis and generate ketones, which can be very much taken by the failing heart hemo concentration. But the real benefit of these drugs is not clear, but it is something to do with the hemodynamics, because the benefits are seen within the first 3 months. So it is a combination or sum total of all these things, but we do not really know what is the real reason why these people get benefited. Now, after these results of EMPA, then followed by CANA, followed by DAPA, the guidelines have evolved in the recent past, and this guideline, which was there in 2019, has changed a little bit now. I'll show you the recent guidelines, which talks about the use of SGLT2 inhibitors in 2 settings. A, as cardio and nephroprotective agents, which is to your left-hand side. If you have got ASCVD or people at high risk for ASCVD, which is people who are above 55 with CKD, that is proteinuria, or GFR, which is 3 or so, and people have got left ventricular hypertrophy or evidence of peripheral artery disease or carotid disease, these individuals must receive GLP-1 analog or SGLT2 inhibitors. Heart failure hospitalization, only drugs which have shown benefit in this setting in controlled outcome trials, that is SGLT2 inhibitors, where DAPA figures prominently. If you have got CKD, again, you should use preferably those SGLT2 inhibitors which have primary studies which included reduction in CKD. Here again, DAPA and CANAFID. Now, this is what I would call a small subset of the overall diabetic population. They also have a role as drugs which do not cause hypoglycemia. They also have a role in weight loss alongside GLP-1 analogs. Cost is the only factor which prevents the use in the other developed countries, but in our country, now that there is a reduction in the cost in the DAPA, almost all the conditions which require SGLT2 inhibition are met with. There is truly no evidence that populations who are not having the risk factors will be benefited, but there is nothing to say that if you avoid hypoglycemia and decrease weight of an individual at a cost that a person can afford, that this person would be harmed. The ESC guidelines, which were having more cardiologists than endocrinologists, had said that if a person does not have pre-existing diabetes, they can be given SGLT2 inhibitors or GLP-1 analog ahead of metformin. and chairperson really clearly remarked as to what are the benefits and harms of interpreting this. But what we are trying to say is that people are trying to put these drugs ahead of metformin, at least when you have got ASCVD. This would also be the case when you have got renal disease. So SGLT2 inhibitors represent a new opportunity for providing glycemic control without weight gain, without hypoglycemia, with some lowering of blood pressure, with some lowering. The cardiology colleague who is speaking to me now, after me, we tell you that 4 millimeter lowering is also good enough. It's as good as 0.9% point lowering of HbA1c. So these drugs provide all those things. They also reduce CV death. They reduce hospitalization for heart failure. They prevent progression of nephropathy. And in people with pre-existing ASCVD, they also decrease MACE. Given that you have all these properties, you have this thing, even people like young people, young boys or girls go for marriage alliances. This is Sarva Guna Sampanna. So SGLT2 inhibitor seems to be having actions beyond glycemia. They also are preventing, especially for heart failure, and this is a very strong pillar for hospitalization for heart failure. They also decrease the cardiovascular outcomes. They also protect the kidney, not just in diabetics, but also in non-diabetics. And in the DAPA heart failure study, the non-diabetic individuals also were found to have decreased progression to diabetes. That means this is another drug alongside metformin, alpha-glucosidase inhibitors, which is now proven to prevent deterioration to diabetes from pre-diabetic. So multiple usages. The reason I am trying to emphasize this is that do not think that these drugs are required only for people who got ASCVD, heart failure, or CKD. Yes, they are definitely indicated there, but they're also having a role in glycemic control, which all of us are striving for, without causing the attendant benefits of drugs like sulfonylurea. With that, I should stop here. Thank you very much for your patient hearing.
Dr. Bipin, that was a great talk. We will take on the questions after Dr. Sanjay's talk. We already have had 4-5 questions. The next speaker is Dr. Sanjay Mittal. He's a Senior Director of Clinical Cardiology and Research at the Medanta Hospital, specializes in multiplane transesophageal and stress, echo, and heart failure procedures. He's been the PI in many national and international trials like the prominent Emperor 1 and 2, SCORED, DAPA, HF, etc. He's been the Assistant Editor, Journal of Indian Academy of Echocardiography and Ethics in Stem Cells. He's published multiple research papers in various international and national journals. Has delivered over 125 guest lectures at seminars, meetings, and conferences. So he'll be speaking on SGLT2 beyond diabetes. Over to you, sir.
Thank you. Thank you, sir. Dr. Ganapathy. I think my slides are visible. It's wonderful to talk on this forum, and after Dr. Bipin Sethi has so lucidly elucidated all the available literature on SGLT2 inhibitors, I would say that I'm a cardiologist, he being an endocrinologist. We are just like those two blind men who are looking at the elephant from different angles and describing their own ways. So I like to put my point of view as a cardiologist, looking at the same data which he has wonderfully depicted, and like to share my point of views on that. So beyond diabetes is what I'm going to speak on. The first thing which is important is that there has been some substantial change in 2010 onwards, because the diabetologists and diabetes management has substantially changed after the glitazone fiasco. We all know that. The thing was the focus on hypoglycemia, lactic acidosis, and weight gain as complications of hypoglycemic agents or anti-diabetic agents had moved on to worsening of cardiovascular events, heart failure, myocardial infarction, cancers, and ketoacidosis, urinary infections, and all. because of the fact there was some reasons. You all know rosiglitazone fiasco. Because of this, it was said thereafter that you have to prove cardiovascular safety for any anti-diabetic agent. This is the recent paper which I quote here. This is published in 2019 in Diabetes and Metabolic Journal. It very clearly shows on a population-based data that the people with diabetes die more frequently with cardiovascular disease, with respiratory disease, pneumonias, and kidney disease and cerebrovascular disease. So the mortality in diabetic is mostly cardiovascular or cerebrovascular disease and kidney disease, and less because of the hypoglycemia and the diabetic complications. The other thing is that as soon as the diabetes is diagnosed and we go ahead within a few months, we know that the mortality of CHD, the cardiovascular disease, myocardial infarction, CVS, and stroke all creep up. And it is the duration of diabetes soon after the onset of diabetes which makes the whole of the difference. And this is what Dr. Bipin very clearly said, that we have to look at not only the diabetic control, but the most of the important things is the cardiovascular and kidney disease, which is the most common way of demise of a diabetic population. So coming on to the beyond glycemic control, Dr. Bipin said that the best control of the glycemia by SGLT2 inhibitors is at best moderate. The best being reported by canagliflozin, but it's almost about 1% fall in the HbA1c. He did mention about the 4 trials, the EMPA-REG, CANVAS, DECLARE, and CREDENCE in the diabetic population, where empagliflozin, canagliflozin, dapagliflozin, and the kidney disease canagliflozin was given. The point was, all of these drugs showed a substantial, significant improvement in the 3-point MACE. Unfortunately, dapagliflozin did not, mainly because of the fact, as Dr. Bipin said, the population actually included many of the people who did not have ASCVD as of now, just the risk factor, 60% of them. And that is why possibly it did not touch the significance levels. However, the real world scenario, what dapagliflozin guys say is a significant benefit which is seen in the real world. About 14% relative risk reduction was seen. The cardiovascular death was whoopingly 38% reduced in empagliflozin. In empagliflozin EMPA-REG trial, all of them were, almost 100% were ASCVD, and that is why the maximum benefit was observed in this particular group of people. The worst group in CREDENCE, 22% relative risk reduction in CV death was noted. The CV death, heart failure hospitalization were also 34% reduced. The heart failure hospitalization reduced by almost 1/3. 35% risk reduction was seen in heart failure hospitalization, and about 40% reduction in the kidney disease progression was seen by EMPA, CANA, and dapagliflozin, and the in CREDENCE trials, the canagliflozin. So this meant that the event rates were much better in these particular trials. So the inference of this CVOT trial, if I can summarize, the SGLT2 inhibitors are considered to be anti-diabetics with favorable CV outcomes. But the other point is, from these CVOT trials, it moved on to anti-diabetics with improved CV outcomes. It was not just not favorable. It was a positive result, so it is improved CV outcomes. And from there, it was also that anti-diabetics with improved heart failure outcomes, not just CV outcomes, the myocardial infarctions and MACE events, but heart failure hospitalization, and also to the anti-diabetics with renal preservation. So these were the important outcomes of all these 4 trials we discussed about. But then came the DEPA-HF and EMPEROR reduced. This was just last year and the last to last year. And these make a huge noise. And it was in heart failure. And myself, being a heart failure cardiologist, I know there's a huge bit of problem because we have both ejection fraction reduced and preserved ejection fraction heart failures. People come in and day out with symptoms. We have some treatment available for reduced heart function, ejection fraction, heart failure in the form of ACE inhibitors, ARBs, and ARNIs, and beta blockers. Diuretics for symptomatic relief, but MRAs have been known to improve the outcomes. However, there is hardly any treatment available for the HFpEF syndromes. We have results awaited for the SGLT2 inhibitors trials also in HFpEF, but as of now, reduced ejection fraction I'm going to talk about. So in diabetic mellitus, we have treatments available, but thereafter, yet the mortality is very high. And there is huge unmet need in heart failure. In reduced ejection fraction, we know despite all the best medication, 75% people die after the index hospitalization to the hospital because of heart failure within 5 years span, despite the best medical therapies available. So we need better medical therapies. HFpEF is still an unmet need because there is hardly any treatment available, as I said. Hopefully the SGLT2 inhibitors would prove some benefit in the trials which are going to come. The cardiorenal syndrome, again, major mortality, and very rightly Dr. Vipin said that the nephrologists say maybe that you would not go on dialysis. Why? Because you possibly would not have time to go on dialysis because the cardiac interventionists and the cardiac events possibly would happen before that. And last but not the least, few patients with HFrEF are treated to the adequate nature. Unfortunately, only 10 to 15% in India, and world over only 25% have adequate treatment of heart failure. So that is the biggest unmet need. And how can we help? SGLT2, Dr. Vipin did mention about the possible pathways, but what we know of heart failure effects on SGLT2 inhibitors is we know that it causes natriuresis, and by natriuresis, it would reduce the preload and heart failure symptoms. But is that alone the truth? Because if that was so, diuretics would be helpful, and diuretics are not helpful in reducing mortality in heart failure. It reduces interstitial edema, well, maybe. Improves cardiac bioenergetics. This is something which is a very big thought process, that the mitochondrial and myocyte metabolism is changed to a high energy productive pathways by utilizing of ketones and fatty acids. And that is what is supposedly likely to be cause of improved outcomes, just not the natriuresis part. That would reduce the blood pressure and the volume, but there is some direct effect on the myocardium. Reduction in preload and wall stress, as I thought about, and this is something which is very important. I will talk about the kidney physiology a little later. So, as I said, it's not just that natriuresis, it does not reduce volume, but surprisingly, reducing the blood volume, yet not a counter activation of renin-angiotensin-aldosterone axis. No hypokalemia, and no increase in uric acid and hyperglycemic effect, which is very common with the diuretics. So this is a specific nature of natriuresis which happens, which is productive for heart failure, much better than the diuretics itself. So the Emperor Reduced and DEPA-HF, these were two trials which were released last year. Both were equivalent amounts and did concede ejection fraction of less than 40% in both the trials, with an elevated NT-proBNP levels. But Emperor Reduced did include a little high risk population. That's why possibly they claim that the results were not showing significant mortality benefit. However, the primary and secondary endpoints were almost the same in both. Time to the first event, educated CV, death, and heart failure hospitalization. Whereas in DEPA-HF, the urgent heart failure visit to the emergency just for the outdoor management also was included. And the key secondary endpoints were inclusive of all-cause mortality and all-cause hospitalization and recurrence of eGFR, which was not so well defined in the DEPA-HF trial. So Dr. Vipin did mention about it, that both the trials did show substantial primary endpoint benefit of almost the magnitude of the same 25 to 26%. But importance was the trial included diabetics and non-diabetics is almost identical proportion, 50-50%. Meta-analysis also has reported about the same because of the fact that the Emperor Reduced trial did not show mortality benefit, just 8% reduction, and it did not touch significance level, the bar crossing the midline. The DAPA-HF did show about 18% reduction, and the bar was statistically significant different. The meta-analysis was also statistically different. So that means they were all trending toward the same side. Probably the difference in the population of the trial is the reason for the outcome differences. Heart failure hospitalization, substantial difference in both the things. So that means it is doing something good for the heart failure hospitalization. And mind it was the span of 24 months the trial was conducted and then prematurely stopped. The DAPA-HF did show mortality benefit, as I said, and Emperor did not. But is it relevant? Because we have two different categories of trials. The EMPA-REG outcome, where the mortality benefit was there, MACE outcomes were better, and the dapagliflozin trial did not show. Whereas DAPA-HF and DAPA-CKD did show mortality benefit, however, Emperor Reduced did not. So it possibly is just the distribution of the patient population, the respective trials, probably less to speak about the difference in the molecules. However, as the data shows, for the heart failure, better outcome from dapagliflozin, and for ASCVD, better outcome with EMPA-REG as of now, the data shows from the clinical trials. So the importance from a cardiologist perspective was the dreaded side effects. If you look at ketoacidosis, if you look at hypoglycemic events, because it was primarily a hypoglycemic drug or anti-diabetic drug, none of the non-diabetic population, which was almost tune of 50% of the total population, had any ketoacidosis or any episode of hypoglycemia. Whatever hypoglycemia happened in the diabetic arm of the two trials, the Emperor Reduced as well as DAPA-HF. None of the patients in the non-diabetic arm had any hypoglycemia. So that means this was substantial. There were certain genital infections which we all have to be cautious about. So after DAPA-HF and Emperor Reduced, the dictum changed a little bit, to me at least. And that was the SGLT2 inhibitors are considered to be anti-diabetics and with improved heart failure outcomes. After these two trials, if I look carefully, it is more of an anti-heart failure with reduced ejection fraction medication with or without diabetes. I'm sorry, this is with or without diabetes. So it is also encroaching into a non-diabetic population with heart failure. And at least after so many years of a dull and lull, we have two great molecules which have come for the heart failure population, the ARNIs and now the SGLT2 inhibitors. And this is what is the sequence of therapy. Blood pressure lowering is at best modest by SGLT2 inhibitors, just 5 to 10 millimeters mercury. But the ARNIs are much more significant reduction in blood pressure. Volume status, only mild reduction by SGLT2 inhibitors, initial diarrhea reduction, then it plateaus down. The kidneys functions does improve by the renin-angiotensin-aldosterone antagonists and SGLT2 inhibitors. And it is important that no hyperkalemia happens with SGLT2 inhibitors. So for us, the heart failure cardiologist, this is the fifth pillar, the SGLT2 inhibitor, which has been added. The neprilysin inhibitors and ACE inhibitors, ARBs, are going to be one and the same pillar because they cannot be combined. Neprilysin inhibitor has to be given with ARBs. So this has to be a single pillar, in my opinion. Beta blockers, mineralocorticoid receptor antagonist, and the SGLT2 inhibitors. This is an important one. And this has been also coming into the guidelines. The Canadian guidelines were the first one to include SGLT2 inhibitors into the armamentarium of heart failure without diabetes population. The recommendation is we recommend SGLT2 inhibitors such as dapagliflozin be used in patients with mild to moderate heart failure with reduced ejection fraction, without concomitant diabetes also. So that is something which has been true. And on 4th of July last year, even DCGI approved SGLT2 inhibitors, dapagliflozin, for heart failure usage. A word about kidney disease. Dr. Bipin did mention about the DAPA-CDK trial. So both RAS inhibitors and SGLT2 inhibitors lead to decrease in glomerular pressure, and that is what leads to protection of the kidneys. But the mechanism is a little different, because SGLT2 inhibitors lead to afferent arteriolar constriction, leading to reduction in blood pressure into the glomerulus and reduction in damage to the glomerulus. And this is mainly because of the negative feedback from the sodium delivery into macula densa, which shuts off the gates, and that's why the afferent arteriolar constriction happens. On the other hand, RAS inhibitors actually lead to efferent arteriolar dilatation, thus by again increased washout of the blood from the glomerulus, thus by reducing the glomerular pressure. Both of them lead to almost the same way of reducing intraglomerular pressure. But there are certain other postulated things which improve the kidney function. That is, increasing the erythropoietin production, by way of which oxygen carrying capacity increases and hypoxemia reduces in the kidneys. It also reduces the diuretic requirement, because it is itself a diuretic, and that's why hypotension reduces, and renal oxygenation would improve because of renal perfusion being better. And it also has a possibility of VEGF expression, which leads to decrease in capillary rarefaction in the kidneys. And this leads to renal ischemia, which is lesser over a period of time. Maybe this is the reason why the kidneys may be protected by SGLT2 inhibitors. No doubt, all the parameters, whether it was dialysis, transplant, or renal death, or end-stage kidney disease, or substantial loss of kidney function, everything was towards the positive side in the SGLT2 trials, which was the 4 major outcome trials we discussed earlier, the EMPA-REG, CANVAS, and the DECLARE-TIMI. However, the 3 trials, basically including the renal dysfunction population, we can describe the renal dysfunction into 2 parts. One is the eGFR and the second is albuminuria. They can be independent of each other, but they have both the harbinger of renal damage. So less than 30, albuminuria, 30 to 300, moderate, and more severe albuminuria, more than 300, or macroalbuminuria could be one of them. eGFR, we all know, more than 90, 60 to 89, 45 to 59, and all. So if we plot a chart here, the credence population was basically 30 to 90 eGFR, which is this population, with a UACR of 300. So they took macroalbuminuria with relatively preserved eGFR, more than 30. On the other hand, DAPA-CKD actually took a little bit more, that is 25 to 75, little less than the credence trial, with a little less albuminuria, 200, above 200. On the third part, the EMPA kidney trial and the EMPA reduced trial, it was actually 2 arms, whether it was an arm where the eGFR was above 20 to 45 without major albuminuria, or major albuminuria with a preserved, relatively preserved eGFR of more than 45 to 90. So this was the population difference between the 3 trials. And I focused on the DAPA-CKD trial. It was something about 4,000 population, and minded about 624 patients, about 14% patients had actually very low eGFR of 25 to 29. And this population was also specifically understood. So there was a substantial improvement in all primary outcome and the composite outcome of renal dysfunction. The renal specific outcomes, as well as composite of death of cardiovascular cause and hospitalization for heart failure, and death from any cause, which was reduced by 31% in the DAPA-CKD trial. This trial was presented just towards the end of the last year. And this is why it was important to be understood that dapagliflozin was beneficial in preventive renal worsening in heart failure. And mind it, 50% of patients did not have diabetes, and the benefit in non-diabetic population was relatively better. Almost 50% relative risk reduction was seen as compared to the diabetic population, which was 36% relative risk reduction, although the number was more. So this is important to be understood, that after this particular trial, the DAPA-CKD and EMPEROR reduced, the SGLT2 inhibitors are considered to be from anti-diabetics with improved renal outcomes to drugs which are renoprotective medications with or without diabetes. Sorry for missing out the without part here. So towards the end, I like to say, out of the drugs which are available and the talk of the time today for a cardiologist, SGLT2 inhibitors have been shown to improve MACE, especially the EMPA-REG outcome and CANVAS, and the real-world scenario for DAPA. CV death reduced, heart failure hospitalization substantially reduced for 30 to 35%. Renal outcomes much better, about 30 to 40%. Albuminuria reduction was there, and all-cause mortality reduction was there. GLP-1 analogs actually reduce MACE and CV death, so that is why they can be a good anti-diabetics for ASCVD patients. However, heart failure hospitalization was equivocal, and renal endpoints did not show major differences. They were equivocal. Albuminuria and all-cause mortality did show improvement with them. ACE inhibitors, again, almost the same lines. ARBs, no major difference in the MACE. However, better outcomes as far as heart failure hospitalization, CV death, heart renal endpoints were known. Statins also the same way were seen. So all these drugs are important drugs for us cardiologists, especially the heart failure cardiologists, to be used. So, ladies and gentlemen, the messages I want to impart here is the SGLT2 inhibitors represent a new opportunity for all the clinicians in the settings of multidisciplinary approach to concomitantly improve glycemic control and reduce risk for renal complications. Though SGLT2 inhibitors lower glucose levels independently of insulin action, the SGLT2 inhibitors are safely tolerated by even non-diabetic population, and there's hardly any episode of hypoglycemia. And mainly for that is because the glycemia or the glucose release into the glomerulus is also threshold based, which is why the hypoglycemia does not happen. SGLT2 inhibitors provide effective glycemic control, but SGLT2 reduces the rate of CV death, heart failure hospitalizations, and not adversely affect the MACE, and possibly reduces progression of renal disease. So, ladies and gentlemen, I'll leave you with this message that SGLT2 inhibitors are drugs for a larger group of population, diabetics, CKD, as well as heart failure cardiologists, which are looking for treatment of a population who have very high risk of mortality and morbidity. Thank you. Thank you,
sir. Thank you, sir, for that wonderful lecture. So we have a lot of questions. So let me begin with the first one. What is the protocol of treatment of diabetes in normal and in patients with CKD? So that's the first question from Dr. Rakesh Gupta. I think this is to Dr. Bipin.
See, in patients with CKD, historically, we used to think that all drugs are contraindicated, but metformin can be used till GFR of 30. 30 to 45, you can use it half the dose, and beyond 45 GFR, you can use it in full dosage. Other drugs that can be used for glycemic control are, of course, DP4 inhibitors with or without dosage modifications. You can also use the second generation or the superior sulfonylureas. However, for nephroprotection, these drugs will actually, whatever we are talking about, I'm talking about oral agents only, will cause glycemic control, will not cause the renal protection. You can use for nephroprotection SGLT inhibitors up to GFR 30, canagliflozin up to GFR 20-25, dapagliflozin. But they will not cause glucose lowering at those GFR. So you have to distinguish between glycemic control versus organ protection. So if you are giving SGLT inhibitors to this group of patients, you are giving them for protection of kidneys, protection from heart failure, protection from another MACE, rather than for glycemic control. Of course, if that doesn't work out, you can give GLP-1 analogs also, but don't give them and the D4 inverts together. And finally, you can also use insulin repaglynide as well.
Okay, so this question is to Dr. Sanjay. Can we use DAPA as the first choice in heart failure in diabetic patients?
That's a wonderful question. So, a DAPA in heart failure population and a diabetic. So this is a double-edged sword. From the diabetic perspective, yes, it could be the first line treatment. But for heart failure per se, it is still a second line treatment. We have to first stick to the beta blockers, the ACE inhibitors, ARBs or ARNIs. If the person remains symptomatic, only then we use dapagliflozin. So that is why we have to stick to what the inclusion criteria of DAPA-HF and Emperor reduced were. They were all on the contemporary heart failure medication. So those drugs have to be the first line treatment as heart failure treatment. But looking at the diabetic perspective, that the person is a diabetic, this becomes a class 1 indication to put them on SGLT2 inhibitors from a different perspective. So you keep on treating the heart failure, you keep on treating the diabetes. So as diabetic, you will start with SGLT2 inhibitors.
Okay. To Dr. Bipin, some patients complain of headache with the first dose of SGLT2 inhibitors. So you want to stop them or you want to wait till it subsides?
Well, I think if somebody is on diuretics and you have you've added this drug and then there's a postural hypotension, you can have some dizziness or headache. But I don't think that given the benefit that these drugs offer, which no other drug offers, in the setting of people with pre-existing ASCVD, heart failure or CKD, I would not stop it with the first indication of a headache, as also if somebody complains of myocardial infection, because you would like to treat that. But if somebody complains of persistent giddiness, I would try to modify the antihypertensive drugs, specifically if there is hypotension. Similarly, weight loss with these drugs, some people really worry because they are not worried. The wife, the daughters, the relatives, they are worried that you are losing weight, you're looking like a patient, as though heart failure patient is not a patient otherwise. I think those considerations can be waived off for the greater good that these drugs do.
Okay. Dr. Syed Ali wanted an opinion on teneligliptin with dapagliflozin versus Remo with DAPA. I think Remo plus DAPA we can't.
Remo with DAPA or Remo with?
I think Vilda. Yeah.
They must be confusing.
Yes.
SGLT2 inhibitors can be used in combination with D4 inhibitors, and whichever you want to choose, that is your choice. It is not because the seminar is that we have to say that you cannot comment, but the cardiovascular outcome trials, the heart failure trials which I mentioned, the CKD trials which were done are not available with the other agents. Therefore, you can be careful if you want to use only the data from the proposed. And this is not me. This is the ADA ESD guidelines which say that for heart failure and for CKD, use drugs which have used CKD endpoints, heart failure endpoints as primary endpoints in the carefully conducted randomized control trials.
Okay, from Dr. Ramesh, why there's a difference in different specialities? He says EMPA is used by endocrinologists and DAPA is used by cardiologists. Why the difference?
This question is to whom?
Dr. Sanjay.
Okay. So it's again, it boils down to the same thing. We are governed by the trials, the evidence which is available. And if you look at the available evidence, empagliflozin actually was the drug which proved benefits in the diabetic population by reducing CV outcomes reduction there, including heart failure hospitalization. Whereas dapagliflozin was the first drug to prove the outcomes benefit in the non-diabetic population by reducing mortality also. Unfortunately, empagliflozin did show benefits in heart failure hospitalization, but failed to show the reduction in mortality. So if you look at my criteria, two things, the morbidity and mortality both coming down, it becomes class 1. if somebody takes a call on this becomes a class 1 indication. So from my side, DAPA has proven both the points. As far as EMPA is concerned, for the heart failure, it has not proven the mortality. It has proven the morbidity part of it. For the ASCVD in diabetic population, I'm minded it was not in non-diabetic population. It was only in diabetic population. It is proven that it improves the outcomes, both the MACE as well as mortality. So it is definitely a drug in a diabetic population to be used in ASCVD concomitant disease. Whereas heart failure, mortality as well as morbidity benefit was seen only with dapagliflozin. And that is why it is more of a heart failure medication.
Okay, this is to Dr. Bipin. How do you compare oral semaglutide versus SGLT2 inhibitors?
Oral semaglutide is more potent for its glycemic efficacy, but we are talking today not about glycemic efficacy. We are talking about the cardioprotection and the renal protection. For that, there is an ongoing trial with oral semaglutide, which is going to prove whether this really is having a cardiac protection or not. So as far as the potency is considered, one of the most potent oral anti-hyperglycemic drugs, causes weight loss, does not cause hypoglycemia, but other benefits are not there. Similarly, the parent compound does not have any benefit for heart failure. So for MACE reduction, GLP-1 inhibitors are actually kept slightly higher, though they produce the benefit after a couple of years, whereas this drug produces benefit, as was shown by Sir also, very early. A combination of both, of course, will definitely give better benefit. But GLP-1 analogs, as is so elegantly showed in that diagram, do not have in the individual trials benefit for heart failure as well as on the hard renal endpoint. Proteinuria reduction, even sulfonylureas do. So I don't think that is a point that you can claim. So as far as oral semaglutide is concerned, it has to prove the benefit in MACE reduction, but I don't think that it will be useful in heart failure as also CKD, but we have to look at the trials and wait for that.
Okay, Dr. Pramod has asked, if you use DPP-4 plus SGLT2, is there a decrease in the side effects like UTI?
The genital mycosis has been shown in the trials, pivotal trials, to be slightly less, and it seems that DPP-4 inhibition at the genital skin or at the candida is probably responsible, or there is a better glycemic control. The reason is not known, but you are right, sir. Genital mycosis side effect is definitely reduced if you have a combination of both these drugs. Over and above that are sulfonylureas, because it is not that it is the glycemic control itself, it is something else. So I think it is a well-known phenomenon. Thanks for pointing that out.
Okay, another question is, anybody can take a 60-year-old elderly, history of type 2 diabetes, CVA and hypertension. Right now his creatinine has gone up to 2.4, A1C is 7.3, he's on gliclazide. Now, should I add DAPA or stop glicla to get the benefits? So what should I do? Anybody can take it.
Even you can take it. So if this person, we want to take away gliclazide for sure, because he will definitely have hypoglycemia with gliclazide, or if you add anything else. You can add a DPP-4 inhibitor with or without dosage modification. Choice is yours. You have got, Monday one drug, Tuesday another drug, Wednesday another drug, Indian, non-Indian, modified, non-modified. That's up to you. And you can add SGLT2 inhibitor, dapagliflozin, for renal protection. I'm not very quick at calculating GFR. There's no nephrologist around, so maybe there is someone there, but I can do that if you want. If the GFR is permitting, you can use dapagliflozin. In our country, as of now, DAPA CKD study has not been approved by DCGI. So you have to use CANA only, because CANA has been approved up to GFR of 30. So you might choose these drugs for glycemic control. And if the GFR is up to 26, you can even use good old alpha glucosidase inhibitors. I'm talking about drugs that do not produce hypoglycemia, because that is a priority for most of us people. That's why sulfonylureas are giving way first to DPP-4 inhibitors and then to the SGLT2 inhibitors.
Okay, I will take this question. Can you combine DAPA with PIO? Yes, you can combine DAPA with PIO. So in fact, the slight increase in weight gain which can happen with PIO can actually come down with when you add this dapagliflozin, and maybe the slight fluid retention which can happen also can be reduced. coming to the last question, can SGLT2 inhibitors be used for primary prevention of CAD in type 2 diabetes? Primary prevention.
No evidence.
No evidence. Fine, I think
in populations which are not having those characteristics, age above 55. If you're talking about the common garden variety of patient sitting in your clinic, 35-year-old computer engineer, whatever, he won't be getting prevention of swab. But we will take comments from our cardiology colleague. The GFR in that patient is 35.
We have only 20 seconds more.
Yeah, 35 is the GFR. You can use DAPA also.
So
yes, sir.
The question which you asked is that not for primary prevention, because DAPA, the declaritimi actually was a failure because of this fact that in risk factors alone, it was not a beneficial drug. So only in SCVD, if you have, that becomes a secondary prevention.
Thank you, sir. I think we have completed all the questions. Over to Dr. Mithilesh or Dr. Amit for the final word.
Thank you, Dr. Ganapathy, for being here as a moderator, and I'm sure we had a large audience. We had more than 1,000 delegates who attended today's session, 1,300 registered, and 1,100 doctors who were watching all of you live today. And I'm sure they have got the benefit and of your discussion today, and they will definitely better off in using these drugs, and which provide immense benefit to the various population. And I must thank our eminent speakers, Dr. Bipin Sethi and Dr. Sanjay Mittal, for such lucid talks which they have presented today. And we are going to continue this spotlight SGLT2 symposiums on every fortnight, so every second and fourth Wednesday, and we will have our speakers and the chairpersons for those programs later on. So thank you very much once again from our side. We have our brand Dapawell, which is dapagliflozin, and the most affordable one, 11 rupees 90 paisa for Dapawell 10 and 9 rupees 90 paisa for Dapawell 5 milligram. Dr. Bipin, just one important point here. 2 days back, DCGI approved dapagliflozin for CKD without diabetes, eGFR of 30. So that was just 2 days back. This news has come in. So this was something new which I thought I'll just share with you. So thank you very much once again to all of you, and good night from here, from all of us at Intas. Thank you once again.
Thank you, sir.
Bye.
Bye, Dr.